Hi, this is Lloyd, and now that you've had a proper look at the pectoral girdle, we'll focus now on our glenohumeral joint. And this is the ball and socket joint at our shoulder. Now, because it's a ball and socket joint and the socket is really quite small, it's quite an unstable joint. It's got a high degree of mobility, so we can move it around a lot, but our body has evolved to have this high degree of motion by sacrificing stability. So we need some extra factors around the glenohumeral joint that help to stabilise the joint. So we've got a few anatomical stabilising factors, the first of which are the articular surfaces themselves. So we have the congruency between the two bony surfaces, so between the really large humeral head and the quite small glenoid fossa. And we've also got congruency between the head of the humerus and the glenoid labrum, which is a ring of fibrocartilage around the outer edge of the glenoid fossa, which helps to deepen the socket and makes the glenohumeral joint more stable. We also have ligaments that are helping to stabilise the joint, and how they stabilise the joint is dependent on, first of all, their position relative to the joint. So if they're positioned superiorly, they will prevent the humerus from dropping inferiorly. And the stability provided by ligaments is also dependent on the tension in the ligaments. We don't want the ligaments being too taut, because that will restrict the amount of movement we can perform at the glenohumeral joint. But on the other side of the coin, we also don't want the ligaments being too lax, as that won't help stabilise the joint enough, and the shoulder will be even more prone to dislocation than it already is. And we also have muscles around the glenohumeral joint which are helping to stabilise the joint. And like ligaments, their action will be dependent on the position relative to the joint that they are in, and also the tone or the amount of tension in the muscles. Now, the advantage of muscles over ligament in stabilising the joint is that the muscles can change their tension dynamically, so act like dynamic ligaments to help to control the position of the head of the humerus against the glenoid fossa, and thereby help to stabilise the joint. Now, there are also a couple of other factors which help to stabilise the joint, and they're not necessarily anatomical. One of these is the surface tension between the articular surfaces. So the glenohumeral joint is a synovial joint, so there's synovial fluid within the joint, and what this fluid does is it helps the two ends of bone stick to each other and not be able to separate. So that's helping to stabilise the joint. And another factor that we have to take into consideration is the atmospheric pressure. So the amount of pressure from the atmosphere pushing against our body, helping to hold the humeral head against the scapula. So we'll now go through these anatomical stabilising factors one by one in a bit more detail, starting with looking at the articular surfaces. So at the glenohumeral joint, we have the large humeral head and the small glenoid fossa, into which the humeral head will sit. And if we look at a radiogram, we can see this large humeral head and this shallow, small glenoid fossa. So these are the bone-to-bone articular surfaces that we have. So we can see that there's a low degree of confluency between the large humeral head and the small glenoid fossa, which means that this joint is going to be relatively unstable. But while it's unstable, it will have a high degree of mobility. So we've looked at the bone-to-bone articular surfaces. Now let's look at the bone-to-labrum. So we have the glenoid fossa, and encircling the glenoid fossa, we have this thick layer of fibrocartilage, which we call our labrum. And because it's around the glenoid fossa, it's called the glenoid labrum. And the purpose of this glenoid labrum is to increase the depth of the glenoid cavity. So it's making the articular surface on the scapular side much larger. So it's increasing the congruency of the glenohumeral joint, thereby making it more stable. Now, the disadvantage of a labrum as compared to bone is that the labrum, because it's made of fibrocartilage, is weaker than bone and so is then more prone to tearing. And quite often when the glenohumeral joint is dislocated, the labrum itself tears, and so this will require surgical intervention to patch it up, and the glenoid labrum will never be quite as strong as it was before, so there's reduced stability at the glenohumeral joint. So moving on now to look at the ligaments, and just as a bit of revision about the pectoral girdle, we have the coracoclavicular ligaments between the coracoid process and the clavicle, the acromioclavicular ligaments between the acromion process and the clavicle, and the coracoacromial ligament between the coracoid process and the acromial process. And these three ligaments, their purpose is to stabilise the acromioclavicular joint and make it so that the clavicle and the scapula move together at the scapulothoracic joint. So we have these ligaments of the pectoral girdle, but then we also have a number of ligaments around the glenohumeral joint. We have the fibrous capsule encircling the joint. Anteriorly, we have the glenohumeral ligaments, which are strengthening the capsule. And we have the coracohumeral ligament from the coracoid process to the humerus, and this is helping to strengthen the superior capsule. So the coracohumeral ligament, because it's superior to the joint, will be helping to prevent inferior dislocation of the glenohumeral joint, while the glenohumeral ligaments on the anterior will be helping to prevent posterior dislocation of the glenohumeral joint and also helping to prevent excessive lateral rotation of the glenohumeral joint. So if we look at a cross-section through the joint, we have the large humeral head having been reflected away from the shallow glenoid fossa with the glenoid labrum around the edge. And we can see three glenohumeral ligaments on the anterior aspect of this joint. So they're thickenings of the capsule anteriorly. And these will prevent that excessive lateral rotation of the humerus and therefore help to prevent dislocation. We have three bands: superior, middle, and inferior glenohumeral ligaments. So staying with the stabilising factors, but now looking at the muscles that are stabilising the joint. And the major group of muscles that do this are the rotator cuff muscles. And there are four muscles in this group. We have the supraspinatus, being superior to the spine of the scapula, infraspinatus, inferior to the spine of the scapula, teres minor, being inferior to the infraspinatus on the posterior of the scapula, and on the anterior of the scapula we have the broad subscapularis. And each of these four muscles will have a subtly different role in helping to stabilise the glenohumeral joint. So these four all act as dynamic ligaments. So they act like ligaments, except they can change the amount of tension in them to help reposition the head of the humerus against the glenoid fossa. So the advantages of this are that they provide active support. So if there's a sudden movement of the glenohumeral joint, the relevant rotator cuff muscles can engage and help to return the glenohumeral joint back to its resting position. The tendons also help to reinforce the capsule, so make the joint capsule stronger, and that helps to prevent dislocation and provide stability to the joint. And all four of the rotator cuff muscles help to pull the head of the humerus medially so that it stays in contact with the glenoid cavity. Now, there are also a couple of disadvantages to the rotator cuff. The main one being that they require energy in order to work. So whereas ligaments are just passively controlling the stability of a joint, the rotator cuff are requiring energy, and so are a drain on our resources. Furthermore, if there's damage to the muscles, such as with frozen shoulder, or if one of these muscles is torn, the support that they can provide to the joint is greatly reduced, and so increases the risk of injury at the glenohumeral joint. So then you'd need to immobilise the joint to help those muscles heal to return to their normal stabilising role. So you can ask your practical facilitators about these supporting factors of the glenohumeral joint, and also post questions and answer questions on the LMS discussion forums, and I'll tend to those and make sure that they're answered. This has been Dr. Lloyd White. Thanks for taking part.